Good afternoon and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with any commercial interests. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually, please have enter your question into the Q&A section, and we'll be glad to ask for you. Also, a link to the event survey will be shared at the end of the program. It is now my pleasure to introduce our guest speaker, Dr. Adewuyi. Dr. Adewuyi is a PGY-3 internal medicine resident here at Northeast Georgia Medical Center with a planned career in hematology and oncology. Dr. Adewuyi's early research examined chemotherapeutic combination strategies for ovarian cancer and has since evolved toward immunotherapeutic approaches with current interests centered on GU malignancies. Dr. Adewuyi completed undergraduate studies at Towson University, Maryland, and earned a medical degree from Ross University School of Medicine. Professional memberships include the American College of Physicians, the Society of General Internal Medicine, and subspecialty societies aligned with hematology and oncology. Outside of clinical training, Dr. Adewuyi enjoys playing soccer. Join me in welcoming Dr. Adewuyi.
So today for the next hour, we're going to discuss oncological emergencies and immune-related adverse events as approach with NCCN Guideline. Our overview today, we'll start with a case presentation, and then after that we'll discuss some main key oncological emergencies. After that, we'll discuss immune-related adverse events, some key organ systems that are usually affected, and some takeaways and questions. Objective today is to recognize common oncological emergencies and their initial management. We'll identify some immune-related adverse events that are associated with immunotherapy, toxicities. We'll understand the pathophysiologies and timing of these immune-related adverse events. Discuss approaches to diagnose and manage the toxicities based on the NCCN guideline, and also the roles of interdisciplinary collaboration in managing these conditions. I have no disclosure. So for our case presentation today, this is a 62-year-old who came in with a chief complaint of severe fatigue, confusion, worsening shortness of breath. Has a history of stage 4 metastatic lung cancer on pembrolizumab monotherapy. Went to the ED with 3 days of progressively worsening fatigue, decreased oral intake, constipation, polyuria, and new onset confusion. He also reported of dry cough and exertional dyspnea that started about a week ago or so. He's on cycle 3 of pembrolizumab, had that 12 days ago, no recent infection, sick contact, no new medication or NSAID use was reported. Prior history of non-small cell lung cancer, hypertension, chronic tobacco use, and no autoimmune disease. Again, he's on pembrolizumab every 3 weeks. 12 days ago was the last dose. And his physical exam with vitals at 38.9, temperature, heart rate of 110, blood pressure at 134/74. He's mildly confused but relatively arousable. He has dry mucous membrane, mild bibasilar crackles, and no focal deficit on neuro exam. Some mild midline spinal tenderness was noted on palpation. Initial lab exam has calcium elevated at 14.8, creatinine of 2.1, potassium of 5.4, uric acid at 13, and ANC of 400 with CRP of 15. X-ray shows patchy bilateral gangrenous opacities. With all of this, we're going to start with the oncological emergency, just kind of discuss some of the things that this patient's presented with. These are life-threatening conditions that result from cancer itself or the treatment. And some of the common ones include tumor lysis syndrome, hypercalcemia of malignancy, neutropenic fever, spinal cord compression, and the treatment-related immunotherapy toxicities. As far as TLS is concerned, result from rapid destruction of tumor cells that end up in releasing intracellular components to the bloodstream and can cause acute renal failure. You can have that resulting in electrolyte abnormalities that can result in arrhythmias as well. Typically, they are associated with highly proliferative hematologic malignancies as seen in acute leukemia, in high-grade lymphomas, but recently they've been seen in other solid tumors as well. As I said previously, electrolytes that are affected with tumor lysis syndrome can be usually remembered then with this puke mnemonic with phosphorus, uric acid, and potassium being elevated while calcium is decreased. So things to watch out for again, acute renal failure, arrhythmias from hyperkalemia, as well as hyperphosphatemia and hypocalcemia. So there are certain criteria for TLS classifications. There are two criteria. Cairo-Bishop TLS criteria is the most commonly used classification, and it basically uses look at laboratory findings as well as clinical findings. So lab findings includes uric acid greater than 8, uric acid level greater than 8, potassium greater than 6, phosphorus above 4.5, and low calcium at less than 7, or ionized calcium less than 4.5. Any two of these plus these clinical findings kind of confirms Cairo-Bishop criteria. Now, the Howard classification criteria is recent, but it's similar to the Cairo-Bishop, except that it's basically looking at things within the same 24-hour period, while this is looking from 3 days before and 7 days after you start treatment after you start treatment. So management of TLS, as we all know, might include hydration, correction of electrolyte disturbance, and reducing uric acid levels to prevent to preserve kidney function and prevent damage. Recommendation for hydration, urine output target has to be urine output target with greater than 2 mL per kg every hour. Another thing is to correct electrolyte abnormalities, and in lowering uric acid agents, rasburicase enhance elimination with allopurinol having to inhibit xanthine to basically excrete uric acid, and febuxostat inhibits xanthine oxidase and can be used in patients that are allergic to allopurinol. One thing to to note with aggressive hydration is in patients that has concomitant heart failures, CKDs, liver failure, you want to consider adding loop diuretics to this patient to prevent significant volume overload. With rasburicase, you want to be very cautious with patients that are being treated with rasburicase that does have G6PD deficiency, because that can precipitate hemolytic anemia. And as far as febuxostat, cost is a big component of it. It's more expensive than allopurinol, just to be aware of. There are certain things that can be done to prevent, and one of the things is to give IV fluids in high-risk patients about 24 to 48 hours prior to chemotherapy, the starting of chemotherapy. Another is to monitor lab, electrolytes, LDH level, creatinine, uric acid. All those levels are important to keep monitoring. Allopurinol can be started at about 24 hours prior to chemotherapy, as this kind of help control the level of uric acid. Now we'll discuss, move on to hypercalcemia of malignancy. This is the most common cause of this condition is paraneoplastic production from PTHRP, especially also in the setting of osteolytic metastasis in patients with multiple myeloma, breast cancer, renal cell cancers. It's classified according to severity. Mild cases with serum calcium less than 12, moderate cases and serum calcium of 12 to 14, and severe cases greater than 14. They typically manifest with symptoms that we know includes the good old stone, bones, groans, psychiatric overtones, in which you can have fatigue, constipation, cognitive dysfunctions, and even renal failure as well. In terms of management, the key is to correct the hypovolemia, calcium excretion, and also decrease bone resorption in this patient. IV bisphosphonate and denosumab are used in this setting, but in certain patients, calcitonin can be considered as an addition to the bisphosphonates or denosumab in patients, especially if they have severe hypocalcemia with serum calcium greater than 14. Recommendations from the Endocrinology Society for mild, moderate, and severe, as we discussed. So mild, they recommend adequate hydration. With moderate patients, the same approach as mild with hydration, but if they are more symptomatic, then you can consider denosumab or IV bisphosphonates. And in severe cases, IV saline as well as IV bisphosphonate and denosumab are recommended as well. In certain special population, glucocorticoid is included. And in these cases, patients with hypercalcemia of malignancy that are related to high calcitriol level. And glucocorticoids are recommended in this patient because they can block the calcitriol ability to increase calcium absorption in the intestine and also help increase excretion of calcium by the kidneys. So basically, it's kind of enhanced the effect of calcitonin. Next, we'll discuss neutropenic fever. IDSA suggests that fever in a neutropenic patient with cancer should be presumed infection unless there is any other cause that is identified. And that's because the mortality rate for this patient ranges from 5% to 20%. And can go up to 50%, especially in patients with septic shock. The neutropenia in this group of patients are due to mechanism from the immunotherapeutic agents, and impact on bone marrow and impaired ability for the immune cells to proliferate. The definition by IDSA is for neutropenia, oral temperature above 38.3, or temperature greater than 38 within an hour with an absolute neutrophil count that is less than 1,000. Onset takes about 5 to 15 days after chemotherapy administration, but can also take up to 6 weeks in certain cases. And viral testing is highly recommended and considered, especially in patients with that are considered high risk. History and physical exam is very important and should focus on every potential site of infection: GI, blood, skin, urinary tract. And these are a list of some common chemotherapies that are known to cause neutropenic fever: alkylating agents to vinblastine. And with this patient, there are two ways you can kind of go with this. You can consider treating them in the hospital setting, or you can treat them at home. Well, how you kind of decide that, you can use two scoring systems. MASC is one scoring system that can be used. And this looks at parameters, this list of different parameters, and you're given a score. If your score is less than 21, you're high risk for serious medical complication, then it's better to be treated within the hospital setting. If you have a greater than 21 or equal to 21, it's considered low risk for serious medical complications, and those can potentially be treated at home with close monitoring. Next system is the SIGN system. It's a clinical index of stable febrile neutropenia, and it basically is a prognostic score for stable patients with solid tumors as well as neutropenic fever, and use different criteria such as COPD, chronic cardiovascular disease, stress-induced hyperglycemia, and monocyte counts to give a score. If a patient with a score of 0 suggests low risk of complication, score of 1 to 2 are intermediate risk, and greater than 3 are essentially high risk. So if you have a score of 21 on the MASC index score and SIGN score less than 3, you can potentially, be followed up outpatient with close monitoring. But in patients that have a MASC score of greater than 21 and SIGN score greater than 3, it's better to be in an hospital setting. Now, when it comes to management for low-risk patients that have a MASC score greater than 21, there are certain antibiotics that can be used. And they're generally completed over a 7 to 14-day course with the expectation that the ANC counts improve. Fluoroquinolones are recommended as the first line, but can also be used in combination in different patient group. So if you have no penicillin allergy, you can use fluoroquinolone plus amoxicillin clavulanate. If you're already on if you have penicillin allergy but not taking fluoroquinolones, you can just give them fluoroquinolones and add clindamycin. And in patients that are already on fluoroquinolone prophylaxis, they're better treated as high risk. Now, for high-risk patients, antibiotic monotherapy with anti-Pseudomonas beta-lactam agents are recommended for these patients without penicillin allergy or risk factors. The key thing to keep in mind here is for any patient with neutropenic fever, any recurrent fever should be treated as a new episode of infection in this group of patients. But these are the different antibiotics with the different patient classification, so to speak, that can be used. Next, we'll discuss metastatic spinal cord compression. This is a very rare but important complication of cancer. Initial diagnosis should involve medical history, physical examination. Presentation-wise, patients tend to have reduced muscle, reduced power, muscle weakness. They can have autonomic dysfunction. They can have loss of sensation, motor weakness, back pain, or even perianal numbness. The important thing to keep in mind, ability to ambulate must be assessed in this group of patients, and that is because our study shows that greater than 80 patients with that are able to ambulate prior to treatment they have a good chance of ambulating after treatment, and less than 50% of those who have experienced any kind of weakness prior to treatment have difficulty to ambulate post-treatment. So how do you go about this? If you know that your patient have a history or you suspect some kind of previous malignancies, and they come in with symptoms that includes spinal pain or progressive lumbar spine pain, pain that is aggravated by straining, nocturnal pain. If they have yes to any of these questions, you can then follow up with neurological signs and symptoms. Limb weakness, sensory loss, difficulty walking, standing, bladder, bowel, sexual dysfunction. If any of yes to any of these questions, better to treat inpatient and get oncology consultation. Otherwise, this patient can, if there is no neurological symptoms, can potentially follow them outpatient with continuous monitoring. Obtain an MRI within a week is very important. Because once you suspect spinal cord compression, the goal is to prevent further damage. You want to stabilize the patient. You want to give pain medication with NSAIDs. Opiate versus a non-opiate has been a little bit of a discussion, and then you can escalate the dose if you start them on any opiate medication. Steroids can also be used to reduce tumor bulk in this group of patients to relieve any spinal cord compression, which can help with neurological status. As far as, again, MRI is critical to obtain. It must be done within a week. If they're outpatient, if they're inpatient, it must be obtained within the first 24 hours. In terms of other interventions, such as surgical versus radiation versus chemotherapy, surgical intervention can be used alone or in combination with radiation. Radiation therapy is widely the most best to use in this case, but systemic chemotherapy can also be used primarily for like hematological malignancies or other chemosensitive tumors. Role is very limited due to the in its acute management because there's slow response. Some chemotherapies are unpredictable versus others. But once you go in the route of surgical intervention, it can be used alone or in combination with radiation. Now that we've kind of covered a little of the acute oncologic emergency, we'll shift focus more into immune-related adverse events, specifically looking at PD-1 and CTLA-4 inhibitors. A little of the epidemiology, these adverse events tend to occur in about more than 50% of patients that are on immune checkpoint inhibitors, with onset starts within days after you start this therapy. The mechanism involved in this case for antigen presentation and processing play a very significant role in the recognition and targeting of cancer cells. Cancer cells are very smart in trying to evade the immune system and find ways to downregulate or lose expression of proteins that are recognized by our immune cells. And that creates an environment of immunosuppression and leads to cancer progression. Research shows that targeting the mechanism of antigen presenting can be a way to treat cancer cells. Common targets include CTLA-4, PD-1, and LAG-3. PD-1 interaction between the T cells and the cancer cells will basically shut off this axis and prevent the downward signal and activation of the T cells, as well as this LAG-3 interaction with these these receptors. But what research have done over the past decade or so is to find ways to prevent those interactions. When there is inhibitors inhibiting the interactions, it basically gives the the T cells ability to have activation downstream and recognize the tumor cells. There has been over the last decade or so, many immunotherapy that has been that's been produced and trying to restore and improve host's natural immune response against cancer cells. There are many more that is being currently developed, but many indications were being used for majority of these immunotherapies, ranging from lung cancer to lymphoma. There are some first lines options that you will use, and there are some that you use during relapse. But the key aim is to improve the response of immune cells, restore anti-tumor activity. Although immune checkpoints are better tolerated than the conventional chemotherapies, but they still have a wide range of toxicities that can originate from their mechanism of actions. And that's the reason why, as clinicians, we need to be able to recognize and intervene is very important. And the NCCN has guideline approach on how to handle some of these toxicities. As I said earlier, multiple organs are affected and require monitoring and management. It's important to know that some symptoms and presentation can mimic other conditions and delay treatment. Some of the most common organ system affected includes the brain, which can give you encephalitis, meningitis. You have myocarditis affecting the heart, including hepatitis with the liver, and so basically any organ system can be affected. This was a study that was published earlier this year, looking at the different immunotherapies and what organ systems are more affected. They looked at about 2,500 patients, and out of those patients who they were receiving PD-L1 inhibitors, about 1,000 to 1,100 of them were able to report up to 1,800 immune-related adverse effects. The endocrine toxicity tends to be what majority of them reported, followed by pathological and hematological, dermatology, and so on and so forth. So gonna go over some of these, at least the top ones, to kind of give an idea of what to do in certain situations. For endocrinological toxicities, they basically result in dysfunction of the thyroid gland, pituitary and adrenal glands. So patients that are on ICI tends to have those glands affected. And it can manifest as hypothyroidism, type 1 diabetes, or even primary adrenal insufficiency. The different symptoms are listed on here with the different diagnoses of what can show up in these patients. For hypoglycemia, if you have a non-glucose fasting that is above 200 or a random glucose that is above 250, you need to consider this patient might have new onset ICI-related type 1 diabetes. And they can present as DKA or even non-DKA. If they're presenting with DKA symptoms, you need to hold immunotherapy until the DKA resolves. If they do not present as DKA, you can basically treat with insulin, control the glucose, and continue immunotherapy. So that's very important for differentiating if they presented as DKA or not DKA. And in certain situations, the C-peptide might be appropriate for the glucose level. In those cases, you just basically want to treat the serum glucose, continue monitoring that, and you can consider this as a form of type 2 diabetes, insulin resistance, or steroid-related hyperglycemia, rather than it being mainly related to the immune checkpoint inhibitors. In patients that have overt hypothyroidism, the key here is to check the cortisol level before initiating any thyroid replacement therapy. And this is to prevent any adrenal crisis. So you want to make sure that you monitor for, you continue immunotherapy if they have subclinical hypothyroidism, but you want to also give them levothyroxine. Before you start this, you want to make sure that you check your cortisol level. And that's to prevent the masking of adrenal crisis. For thyrotoxicosis, you want to consider propranolol, 10 milligram every 4 to 6 hours, and monitor thyroid function. And if that is not resolving about 4 to 6 weeks after you check, then you can consider grave disease in this set of patients as if there is persistent thyrotoxicosis ongoing. And patients that have hypophysiology, the initial assessment recommendation includes looking at cortisol and ACTH level. Brain MRI is very important to obtain in this set of patients, especially if there's any concerns for mass effect. For those patients, you want to hold immunotherapy until acute illness resolve. You also want to look into secondary adrenal insufficiency, especially if they have low ACTH or low cortisol level, and if they have any central concerns for hypothyroidism, thyroid hormone replacement is essential. Primary adrenal insufficiency is very rare, but for those group of patients, they recommend an endocrinology consultation for those group of patients, but you can also start them on steroid based on if they have a stress dose steroid versus non-stress dose steroid based on the patient presentation. For liver and pancreas, so the immune-related hepatotoxicity in this group of patients occurs very at a lower rate than the GI side effect of diarrhea and colitis. You'll see more of the diarrhea and colitis than liver involvement. And asymptomatic elevation in AST/ALT are commonly observed in hepatic adverse effect. For patients that have diarrhea and colitis, you want to make sure that there is no other source of what's causing the elevation, what's causing the diarrhea and colitis. So stool evaluation is very important. GI pathogens, you can obtain those to rule out any other infectious sources. Consider obtaining a CT, abdomen, pelvis, colonoscopy or flexible sigmoidoscopy with EGD and biopsy can also be obtained. For this group of patients, it's important to hold therapy. Start them on IV steroids, and if no response after 3 days, you want to consider adding other things such as infliximab to their regimen. In patients that have transaminitis, you want to rule out any other cause of what can be causing the elevated liver AST/ALT. Rule out other viral etiology. And these patients are basically looked at in terms of if they have how far away from the upper limit of normal their values are. In patients that are graded as G1 with less than 3 times upper limit of normal, they're recommending performing liver tests with increased frequency. Consider holding the immunotherapy, but based on patients out the present, you can also continue it in G1. Patients that have, for G2 recommendation with about 3 to 5 upper limit of normal, you would definitely want to hold immunotherapy at that point. Monitor PTINR and consider starting them on prednisone. And for patients with G3, G4 grading that have greater than 5 to 20% in G3 and greater than 20% upper limit of normal, you basically want to start them on high-dose steroid with methylprednisolone and continue monitoring liver tests every 1 to 5 days. In G3 and G4 is even more frequent, monitoring every 1 to 3 days. Periodically monitoring the PTINR is very important in either G3 or G4 grading. So a quick summary here is, in severe cases, hold immunotherapy, start high-dose steroids, get GI pathology to see the patient, and in case of transaminitis, just try and figure out if there's any other causes, rule out viral myositis or other hepatotoxins that the patient might be taking. Next, we'll move to blood. For this patient, you can have hemolytic anemia, aplastic anemia, or HLH-like syndrome. And hemolytic anemia will present with pallor, dark-colored urine, jaundice. Aplastic anemia can be present with symptoms secondary to the anemia, thrombocytopenia, neutropenia. The HLH, patient might have unexplained fever with hepatosplenomegaly. They can have hypofibrinogenemia and even elevated ferritin in certain cases. For the hemolysis group of patients, you want to obtain labs to ensure that there is evidence of hemolysis. So If they fall under grade 1, which it's only laboratory evaluation, you want to hold immunotherapy and consider hematology referral. But for G2, in which the hemolysis is more significant, greater than 2 grams drop in hemoglobin, prednisone once daily with holding the immunotherapy is recommended in those patients. For grade 3 patients that are requiring transfusions, you want to transfuse them according to your institution guidelines, but also continue start them on methylprednisolone 1 mg per kg once daily. If there is no response to the steroids, as well as to rituximab, you can then consider tacrolimus, cyclophosphamide, or mycophenolate. For grade 4 patients that have hemolysis and is life-threatening, start a steroid, consider adding rituximab, and if no response, there's even more medications that you can consider in those patients. So grade 3 and grade 4 in this case is very similar in terms of how you're going to manage them. You want to make sure that you discontinue immunotherapy in those two grades. For HLH-like syndrome, HLH is basically like a life-threatening syndrome of immune activation that can basically result in like widespread inflammation and tissue destruction. In this patient, you can use this HS scoring system to help estimate the probability of diagnosing HLH in adults. It uses 9 clinical and laboratory variables, and with I-score indicating the likelihood of HLH. And for those patients, you want to start them on steroid, and if no response, similar to the what was in our prior slide with hemolytic anemia, you can also start them on a couple of those medications, tocilizumab and anakinra, and so on. For patient with aplastic anemia, you want to make sure that you discontinue immunotherapy, monitor their red blood cells and platelets and transfusion if needed, but also you want to consider growth factor support for this group of patients. Steroid is important in these patients to start as well. All right, so quick takeaway here, hold immunotherapy if needed, start steroids, prednisone in the case of hemolytic anemia, and consider rituximab. If those are not working, you can move on to the second-line immunosuppressive agents, and also on consultation. Next, we'll go to dermatology. So they can present with various symptoms: bullous dermatitis, maculopapular rash, pruritus, SGS, and TN. Some patients might have lichen planus, psoriasis, oral mucosal inflammation, dry mouth and oral dysesthesia is also part of what can be seen in this patient. Vertigo is fairly commonly observed in patients with melanoma or PD-1 inhibitors and can present later in the course than earlier. So with patients that have bullous dermatitis, you want to get a skin biopsy. If they are very mild, G1 grade, hypotensive steroid is required. You can hold immunotherapy. For grade 2, start them on methylprednisolone. And if diagnosis of bullous is confirmed by the biopsy, you can consider rituximab or dupilumab. For G3, you want to discontinue immunotherapy in those patients. Start methylprednisolone and consider IVIG. In patients that have Stevens-Johnson syndrome or TEN, again, if dermatology consultation is not available, get skin biopsy. Permanently discontinue immunotherapy in this patient just because of how these patients can present, and consider IVIG as well as methylprednisolone in those group of patients. In patients that have maculopapular rash, if they present as mild, you want to use topical emollients and consider oral antihistamines for them. For G2 patients, you want to continue immunotherapy and as well as using topical emollients in those patients too. If they're unresponsive, you can consider prednisone. And for G3, G4, you want to hold immunotherapy, high-dose steroids, and consider keeping them inpatient. Patients that have pruritus can have different, it depends on the body surface area that has been affected. If in very mild case with G1, whole body moisturization is important with moderate potency steroids. With G2, you want to consider using gabapentinoids as well as high-dose steroids and get the dermatologic consultation if you have one. And for G3, high-dose steroids, gabapentinoids are recommended. And if no response, you can consider dupilumab, omalizumab, or other UV, narrowband UV phototherapy to use in those cases. For lichen planus and lichen disease, if less than 10% of the total body surface area is affected, it's okay to continue the immunotherapy and just start them on high-dose steroids. If they have moderate 10 to 30% of the total body surface area, you can start antihistamine as well as prednisone. And if it's greater than 30% of the body surface area affected, high-dose steroid, methylprednisolone, dermatology referral. In these patients, you want to hold immunotherapy as well. For psoriasis and psoriatiform disease, also depending on the body surface area that is affected, if it's less than 10%, you can continue immunotherapy and put them on vitamin D analogs. 10 to 30% hold immunotherapy, vitamin D analogs, and again, you can consider these medications. And if they have more than 30% body surface area, you can also continue holding immunotherapy, vitamin D analog, high-dose steroids. And if they're not responding, you can consider these other medications as well. Dermatological referral is also important. So quick takeaway from this, lichen planus and psoriasis in mild cases, immunotherapy is important and use high-dose topical steroids. In moderate to severe cases, you want to hold immunotherapy and use topical or systemic therapy. And for pruritus, antihistamine topical steroid in mild cases, but if severe, you want to start systemic steroids. For bullous dermatitis, urgent dermatologic derm consultation is important. And for SJS and TN, discontinue the immunotherapy, inpatient admission with high-dose steroids and IVIG are important for those patients. We'll discuss oral mucosal inflammation. And for this patient, a comprehensive mucosal exam is very important in this population. Basically want to look and make sure that there's nothing else that you're kind of missing in that point. Dietary modification is essential and good oral hygiene generally for this group of patients. Now, if they have issues with some food restrictions, you can consider continue the immunotherapy, but acid suppression in those group of patients. And if they can only do soft pureed food, hold the immunotherapy in this case, you can consider starting them on a high steroid, and tacrolimus can be combined for these patients. Lip or oral biopsy is clinically indicated, if clinically indicated, but not something that you will that you will do for this group of patients. And if patients are unable to eat, you want to put them in patients, start them on high-dose steroids. Again, lip or oral biopsy is not something that is being recommended for this group of patients as well. Patients that have dry mouth, if it's very mild, you can continue the immunotherapy and also change dietary for them. You can give them salivary stimulants to kind of help. If they have G2, G3 grade you hold immunotherapy and have dietary changes for them. Steroids, prednisone 20 to 40 can be given, and then you can kind of taper, or you can use systemic cyanogogules. For patients that have oral dysesthesia, if it's very mild, in dietary modifications, as well as topical steroids is important. If they are very moderate, you can want to consider gabapentinoid or high-dose topical steroids for those group of patients. So takeaways here: if they have rheumatocytitis, continue immunotherapy and topical comfort measures. If it's severe, hold immunotherapy and use steroids as well as systemic steroids. For dry mouth, you want to consider giving other substitutes, saliva substitutes, stimulant, symptomatic care, and hold immunotherapy. And for oral dysesthesia, you want to continue immunotherapy, topical analgesics or steroids in mild cases. In severe cases, consider gabapentinoid and high-potency steroids. There are some population of patients that will come in with pneumonia, dry cough, shortness of breath, fever. For those patients, based on if they're mild, moderate, or severe, you can consider holding immunotherapy in these patients and repeat chest CT in about 4 to 6 weeks to kind of assess their level of improvement. In moderate cases, you also want to hold immunotherapy. You can consider infectious workup like nasal swab, sputum culture. Most of this will come back not really being equivocal. You can also use invasive evaluation if your patient is, if you feel like they're getting worse, and consider empiric broad-spectrum antibiotics. But high-dose steroid methylprednisolone is kind of key in this set of patients. And in G3 severe cases, you want to discontinue the immunotherapy. POM and ID consultation, start broad-spectrum antibiotics as well as IV methylprednisolone in this group of patients. And there's a quick takeaway from that. Is considering holding in mild cases and close monitoring. Moderate case, you want to hold immunotherapy and start steroids. ID and pulmonology consultation. In severe cases, discontinue immunotherapy. For cardiovascular impact, recently I actually saw a patient with this, came in with chest pain and basically looks like what you were expecting, a patient with STEMI. Underwent left heart, right heart cath, everything was clear. The only thing that we can point to is that he just recently, about 2 weeks ago or so, completed the second dose of one of those ICI medications. This patient can come with chest pain, dyspnea, fatigue, palpitation, and this can come in conjunction with like myositis or myasthenia gravis. So you need to rule those things out to make sure that that's not what they're presenting with. Recommendations here is to basically prevent them from going into fulminant myocarditis. You want to obtain an EKG, telemetry monitoring. You also want to do echocardiogram. Biomarkers is essential. You want to make sure that they're not having myasthenia gravis or myositis that can kind of overlap the symptoms. And cardiac MRI. Key treatments: discontinue the immunotherapy, start them on high-dose steroids. The patient was started on methylprednisolone 1 gram per day for 5 days, and while we're obtaining the cardiac MRI, just to make sure that this is actually what the patient has. Now, if the MRI comes back and it's not, well, then you can basically discontinue the steroid, but at least you jump into action to prevent them from going into fulminant myocarditis. And also, it's important to have this patient in an ICU level setting. So key points: discontinue immunotherapy immediately, consider ICU level, cardiology consultation, and high-dose IV steroids as well. So with this, Gonna just go into a quick management principle for this set of patients. So if your patient presenting with symptoms related to grade 1, very mild, you can continue to monitor them, continue the immune checkpoint inhibitors. But as soon as you're moving into the grade 2, grade 3 level, you need to reconsider how is this continuation going to affect them. Holding the immune checkpoint inhibitors, starting them on steroid, and for grade 3 and grade 4, you basically want to just discontinue the immune checkpoint inhibitors, using either steroids and also consider other immunosuppressants. Consultation with other disciplines is very essential, especially in order to improve outcomes for this patient. Some of the challenges here is recognizing what this patient actually come on with, because they're basically similar to what you will see regularly, and understanding that after you've looked at, ruled out everything else, the only picture that you can get from this is probably due to what they've been on. Is very important. And in trying to balance this cancer treatment with immunosuppression, especially in patients with deciding if you want to hold immunotherapy or continue immunotherapy. With that, we have two questions that I'm going to go over. So first question, there's a 47-year-old woman who is hospitalized for induction chemotherapy and treats newly diagnosed AML. History is unremarkable. On third day, she has muscle spasm, dyspnea, worsening lower extremity edema, but no fever. Vitals with blood pressures, 159/70. But when the cough is inflated, she develops spasm. Mild respiratory distress, respiratory rate of about 25 breaths per minute. Crackles are audible, jugular vein is distended, right heart, her heart rhythm is regular with rate in the 120s, and she has 2+ systemic lower extremity pitting edema. Serum creatinine level decreased from 0.9 1 week ago to increased from 0.9 to 3.7. Urine output dropped despite aggressive volume expansion and even after a trial of IV furosemide. The lab values are as follows. Leukocyte count is quite high. Hemoglobin is kind of okay. Platelet is low. Sodium is low. Potassium is high. Calcium is 6.5. Phosphorus 8.7. Uric acid 18. Albumin 3.9. They obtained a urinalysis that shows trace blood, 2+ protein, pH of 5.2. Urine microscopy that shows about 2 red cells per high power fields and white cells 0 to 2, uric acid crystals and granular crystals. Question is, in addition to consideration of urgent dialysis, what else would you do? Would you give febuxostat, allopurinol, respiricase, or urine alkalinization?
C?
And
B
C is the
or
right
C?
answer. Okay.
Which is correct?
C.
C.
Yes. Okay. So this patient will require respiricase. So aggressive volume expansion improve renal perfusion and kind of minimize uric acid and calcium phosphate precipitation in the tubules, which is key to preventing TLS. In a patient with this established hyperuricemia, respiricase is recommended. And also remember that these patients, they're at risk of developing methemoglobinemia or hemolytic anemia, especially if they have G6PD deficiency. So that's something that you need to make sure that your patient does not have. So test them before you can start them on this medication. Second question. 74-year-old man present to the ED with 2 weeks history of weakness, dehydration, profuse diarrhea, has 10 bowel movement daily that described as loose, watery, non-bloody. He has mild abdominal pain, no fever, nausea or vomiting. Medical history is significant for COPD, hypertension, gout, recently diagnosed metastatic unresectable melanoma, and was started on ipilimumab for the past 7 weeks. He denies any sick contacts, no travel, no antibiotics, and has not experienced any other symptoms. Temperature of 38.6, heart rate of 110, blood pressure 102/55, and he's doing well on room hair. Physical exam reveals dry mucous membrane, poor skin turgor, cardiac, lung exam are fine, abdominal exam, some diffuse mild tenderness, no rigidity. You obtain a CBC and liver testing was normal, and these are the labs. Sodium of 129, potassium of 3.4, creatinine 2.4. His baseline is at about 1.2. Because of the diarrhea, you obtain these 2 studies, including culture ovarian parasites, C. diff, all those are negative. You get a CT abdomen pelvis with oral contrast that shows pancolitis. There is no perforation, stricture, fistulas, or any abscess. You move on to the colonoscopy, did a colonoscopy, and even got a biopsy that showed mixed lymphocytic infiltrates, negative for CMV, protozoa, and any granulomatous. So you start the patient on supportive management with IV fluids and antidiarrheal agents. So which of the following is also important in this patient?
D as in dog.
Let's try again.
Oh, try
A
again.
or B?
Oh,
50-50.
A or B?
B.
B as in boy.
Yeah, that's the correct answer. So in this patient, just because of how they present, you want to stop indefinitely, they fall into the category of grade 3, grade 4. So for those patients, you want to stop ipilimumab, start them on prednisone. Again, this patient is experiencing immune-induced colitis, and something with those group of patients, if they're having diarrhea less than 4 episodes, they're falling under grade 1. Grade 2, 4 to 6 episodes daily. Grade 3 greater than 7 episodes, and grade 4 is like, life-threatening for them. So for our patient, is in the grade 3 disease range with greater than 10 daily. So you need to stop the ipilimumab and start them on IV steroids. And that's all. So, we've taught the immune system to see cancer. Now we must be the one to see the immune system when it fights too well in the wrong places. And with that, I'll take any questions. Special thanks to Dr. Gross and Dr. Koroma as well.
Great. Thank you, Dr. Adewuyi. If you're viewing online and have a question, please enter it in the Q&A section, and we'll ask that for you. But in the room, do we have any questions or comments?
Wonderful presentation. Seriously, immune-related events has been under-recognized, and we don't identify these patients frequently. But has there ever been a situation where you've seen more than one immune-related events happening at the same time?
There could be. It's definitely possible. And again, this is because this, the way this medication works, they can invoke inflammation in any system. And it can happen at the same time. Yes, it's possible. Yeah.
Thank you.
All right. Thank you, Dr. Adewuyi.
Thank you.